I'm really excited to welcome Dr. Kim Dennis from SunCloud Health today to join us for a webinar on some of these controversial terms and to just really dive into this topic some more. So just a little bit of background in case you haven't already had the opportunity to meet Dr. Kim before. She is the co-founder and CEO and Chief Medical Officer over at SunCloud Health, a board certified psychiatrist who specializes in treating eating disorders, addiction, trauma, and multi-occurring disorders. She believes in and maintains a holistic perspective in the practice of psychiatry, incorporating biological, psychosocial, and spiritual approaches into nuanced individualized treatment plans. So, Dr. Kim, I'm very excited to pass the mic over to you. Just so everybody knows, feel free to post any questions in the Q&A, and we will open this up for a discussion a little bit later on. But Dr. Kim, the floor is yours.
Awesome. Thank you so much, Jason. Thanks to you for all of the legwork to get this webinar actually happening today, and also to ANAD for supporting it. And I'll start with just some disclosures. I'm a board member at Galen Mental Health, a board member for the Eating Disorder Coalition. I have white and thin-bodied privilege. And we will talk a little bit in this discussion today about bias. And bias comes from several different places. I know for me, privilege is part of that with regards to race, gender, size, sexual orientation, ability level, socioeconomic status, access to healthcare, access to safe green space, and more. And bias also comes from discipline-specific training. I'm medically trained as a psychiatrist, went to medical school, went to psychiatry residency training, and that training comes with a certain, I left that training experience with a certain frame. And different disciplines carry different frames from their specific training programs. And then there's specialty and subspecialty training. Right. So my eating disorder training and the eating disorder experience that I've had and direct patient care work with patients who've had eating disorders impacts my bias or my frame. And what's not as much talked about, but is becoming more and more of the conversation, is lived experience, which I think is really, really important. And I'm a person who is a doctor and has been clinically trained, but I also, before I became a doctor, what was deeply influential in my life was my lived experience with recovery from bulimia, alcohol use disorder, food addiction, and childhood trauma, complex trauma. And being aware of why is this important? When I'm aware of my own experiences, when I'm aware of how they've impacted the way that I see the world or the things that even that I've been drawn to as a professional, I have a little bit better chance of being able to meet the patients that come to me and set that aside to entertain the possibility that even if a patient has the same set of DSM diagnoses as I may have one day had, that their experience and their unique disease might be very, very different than mine. When we talk about controversy in the eating disorder field, and the context for this, I'll share just a little bit about the sort of how the idea of this webinar came to be. And I had written a blog for ANAD about my lived experience, and they took the bold stance, and I'm very, very grateful for that, of actually publishing it, even though I talk about, more than just my eating disorder recovery, right? My substance recovery. I talk about my experience with food addiction and being recovered from it. And, I know that ANAD, caught some flack for that. And the whole point of my blog was really about community and being inclusive And as an eating disorder community specifically, being able to include more people, people who have eating disorders, who may be marginalized or who may be silenced, or certain aspects of their stories silenced. And again, I'm grateful that ANAD let me tell my story in my words. And I understand that it was controversial, and it is controversial. And I think for lots of reasons, and that's part of why we're here today, to talk about some of those. I think it's always important to start with where we are unified. Where is the common ground? And I think every single person on this webinar is here because we all want to help people with eating disorders. Nobody has come to this webinar today because they want to, harm patients or harm loved ones who have eating disorders. And that's sort of ground zero. And if, whenever I feel myself, if somebody says something that's maybe different than what I believe, or that feels like an attack, if I could go back to ground zero and remind myself that we're all here because we care very deeply about people with eating disorders, that goes a long way in having these conversations. And I think we grow from these conversations. So I also think that we can sort of get on the same page with regards to eating disorder treatment pillars, right? Renourishment, weight neutrality, combating weight stigma and diet culture, cognitive distortions associated with eating disorders, helping people focus on, values and intuition rather than what big tech is telling them or what media is telling them, helping people increase variety and flexibility, helping people have more in the way of self-compassion, improve relationships, and at the end of the day, a higher quality of life. When we think about recovery and recovery from eating disorders, who gets to define what recovery is, and who gets to define who is recovered and who is not, or who is in recovery or who is not? Who gets to define health for any given person with their own complex lived experience, life experiences, ancestral, their ancestry, multi-generational traumas, genes, strengths, and challenges? How do we define recovery? And how do we define how to get there? What's the right way? So there's a lot of fragmentation that happens, particularly around some controversial areas in the eating disorder world. When we talk about weight neutrality, right? Weight neutral, are we really weight neutral? Or fat positivity, or fat phobia, or health consciousness? Who gets to say? When we talk about all foods fit, right? When we think about the mainstay of nutritional therapy for patients with eating disorder, it's almost uniformly all foods fit. Do they always? For all people, all the time? How about the F word? I'm not talking about that one, but I am talking about food addiction. And I think for me in my career, these last 20 years, that has consistently been a flashpoint among eating disorder circles. And in the last 20 years, I've understood more and more and more about why that is. And I actually see a little bit of movement in the direction of an opening up a bit, which has been wonderful to be part of. A sort of offshoot of the food addiction discussion is, and this is something that was brought up in Susan McElroy's recent article in the International Journal of Eating Disorders, is all dietary restraint pathological? We know that dietary restraint is a risk factor and a core feature of having an eating disorder, and shows up in eating disorders from anorexia, OSFED, atypical anorexia, binge eating disorder, bulimia, all of them, the whole range. But is all dietary restraint pathological? We'll talk about that. So why are these conversations so important? First and foremost, to save lives and to reduce human suffering. Secondly, to help us grow and learn and to be better equipped to serve. Thirdly, to stop stigmatizing and further marginalizing folks with eating disorders who don't toe the party line. You know, people who don't, all of the people who either, you know, patients will say, I've been rejected from eating disorder treatment, or I've been rejected from this program and this program and that program. And usually what they mean is they've been administratively discharged or discharged because they wouldn't do X, Y, or Z thing that they had to do in order to be in that program, right? So I think when we look at outcomes, for people who do receive care, when we think about all the people who never even make it to accessing care, when we think about all the people who don't even if they had access to care, wouldn't access care because they read about what care must mean and they don't want any part of it. I think we have a lot of room to improve and a lot more people that we could be helping and including in our treatment efforts, in our research efforts, in our advocacy efforts. We know that data shows that mortality rates skyrocket when eating disorders and substance use disorders co-occur. So at the very least, we need to address addiction, addiction involving substances, right? Rates of mortality increased by a factor of 22 for people with anorexia who are also misusing multiple substances. And this is already a very high mortality rate, you know, second highest of any of the mental illnesses. We also know that we continue to hear people who have binge eating disorder experiencing, you know, feeling like they're being poorly served in many eating disorder settings, and, you know, having the experience that eating disorder settings are primarily focused on restrictive dimensions of eating disorders and people with anorexia and bulimia. When we look at the eating disorder recovery rates, the data shows that we have a lot of room to grow. This is a study that was just published this year, and it included 88,000 people from all continents except Africa. Mean age was around 25, predominantly female, 72%. And the follow-up was, you know, around 4 years. And it included all of the different eating disorders, anorexia, bulimia, binge eating disorder, and OSFED. Overall recovery occurred in 46% of patients. So that leaves 54% of patients who maybe experienced improvement, but didn't experience cure. The recovery rate increased from 42% at less than 2 years to 54% at 4 years, 4 to 6 years, and then 67% at greater than 10 years. So over time, more people recover, but there's still 33% of people who do not experience recovery after a decade. And that says to me, as a clinician, as a scientist, that there's something that we're missing, right? That at the very least, there are things that there are going to be tools, if we're open to learning them and exploring them, that are going to help more people. And I'm, you know, in my career, I've been particularly interested in that 33% of people who are not adequately served by current treatment standards. Overall chronicity occurs in 25% of patients. And when we think about eating disorder professionals as a group, I count myself as a person among them, and clinical bias that we carry. How often do we really listen to people with eating disorders? How often do we pathologize them? What's the difference between a patient preference and an eating disorder symptom? And who gets to say, right? We mentioned All Foods Fit. All Foods Fit is the gold standard nutritional approach applied nearly universally again, in eating disorder care, which means all foods in moderation, eaten in an intuitive way, fit for all people. Do we really believe that one approach is best for all patients? I don't think so. Who gets to define recovery and how we get there? How we get there nutritionally? Do we individualize this? Do we contextualize this for the patient in front of us? Or do we use a philosophy and apply it across the board? What if a patient says a certain type of food does not fit for them? Do we consider that, again, eating disorder pathology, or do we consider that potentially the person's preference or potentially the person's biological truth? And then how do we know, right? Is it possible that there's a difference between pathological dietary restraint and non-pathological dietary restraint? And what would that even mean? What would that look like? So this is a nice picture to, I think, spell out part of what I'm talking about. When I ask people, what is your food philosophy? Almost always eating disorder clinicians say all foods fit. And then I ask for every person. And in eating disorder settings, usually in eating disorder treatment settings, usually the answer is yes, because everybody needs to be doing the same thing. Otherwise, person X is going to be upset that person Y gets to do whatever person Y is doing. How about all foods fit for many people or for most people, but not for all people all of the time, right? So plurality is what we're talking about, and expansiveness. And again, not just for philosophical reasons, but to really increase our capacity to help those 33% of folks who currently are not helped by standard eating disorder treatments. And if you're, I know that some of the folks on this webinar are people who are here from the community with lived experience. Some of the folks are clinicians. And if you are a person with lived experience in the community that hasn't been served well by X, Y, or Z therapist or therapy approach or eating disorder approach, keep seeking, because there is help, and there are lots of different forms of help. So all foods fit for all people all the time. Do all drinks fit for all people? How about those with alcohol use disorder? Does propranolol fit for all people? Propranolol is a blood pressure lowering medication that's also used for anxiety. It does not fit for people with asthma. It makes it very, very hard for those people to breathe. Mm-hmm. But it's a good medication, and it works for a lot of people. Is there bias and privilege embedded in intuitive eating? And I am a big fan of intuitive eating. I believe in intuitive eating. But what are the necessary prerequisites for intuitive eating? And what does intuitive mean? Who gets to say? What about the large numbers of racially minoritized and socially economically disadvantaged folks who may not have had the privilege to be able to safely and affordably access all different types of food when they want them? And when we adhere to dogma, it diminishes our capacity to serve. It diminishes our capacity to help, particularly those folks on the margins. It keeps us insular as a field. It kind of shrinks us. It very much limits, it interferes with our capacity to learn from peer-reviewed research, from scholars, from other fields, and from patients. And many patients are inadvertently stigmatized by rigid definitions of recovery, again, largely centered on white-bodied people and restrictive dimensions of eating disorders. So we know that no one size fits for everybody in eating disorder treatment. And that applies to nutritional philosophies, treatment modalities, definitions of recovery, medications across the board. But in the United States, in our medical system today, individualized care is harder and harder to come by. What about food addiction? Does this question itself elicit an emotional response in any of you on the screen? Just pause and think about that. And if so, do you know what the emotions are and why? Does food addiction exist? Or is it just a cover for people or clinicians to espouse diet culture, healthism, weight loss? How will we know? Who do we listen to and whose voices do we silence? What does the research say? Do we read it? Do we discount it? Do we ignore it? How about the lived experience of humans who say they have it? Do we listen? Do we silence them? Do we pathologize them? Do we smile and nod while thinking secretly in our heads, this person clearly didn't have good eating disorder treatment? Do we attack them? This is a quote from a patient who knew I was doing this webinar today and who asked me if I would share a quote from them. And clearly I'm not going to share the patient's name, but from my perspective, anything that might make someone shame themselves is bad. So wouldn't it be nice if the ED folks could see that telling a person with food addiction that all foods are equal will create a lot of shame, arguably just as much shame as someone fat shaming me or me fat shaming myself. This is a larger bodied person with multimorbidity. I think a lot of the emotion that comes up around the term food addiction arises because different people probably mean different things when they say it. Different people probably conjure up different things when they hear it. And some of the language that is often associated with food addiction, I think, is part of the stigma and the bias. Substance abuse, right? This abuse word, addict or addiction, out of control, toxic, unsafe. Abstinence, like, does food addiction mean abstinence? That sounds like restriction. That sounds like weight loss. Harm reduction, is that for the people who are just sick to really recover? Or is that a treatment modality, a treatment approach in and of itself, a legitimized, solid, evidence-based treatment approach? Is that person recovered? Is that person in recovery? Do we judge somebody who shares lived experience? I can tell you, as a physician and eating disorder professional who's been open about my lived experience, I've certainly been judged about it. You know, not usually to my face. It's usually, you know, politely in a separate room. But I've also, you know, had a lot of experience, particularly when I give talks like this on controversial topics, have had people message me afterwards or have individual one-off phone calls about food addiction. And I think I have some patients who might have that. And I'm glad you're talking about it, but please don't tell anybody I told you so. So clearly a lot of energy and a lot of emotion and a lot of fear around this topic. Intuitive eating. Is intuitive eating compatible with you know, any of the multiple treatment approaches that someone might take for a person who has an eating disorder and food addiction? I can tell you intuitive drinking is compatible with living a life in sobriety for me. You know, I intuitively, like, don't drink alcohol. It didn't work too well for me. And I'm very grateful today that I am empowered enough and have the power to know that and to make that decision for myself. At the end of the day, it's really about all recovery, I believe, is really about freedom, personal freedom. And that's not something I can define for a patient. That's not something you can define for me. That's an inside job. So I want to say a little bit more about food addiction. It's a conceptualization of out of control eating and related behaviors. It's a substance addiction when I talk about it, and generally in the field and in scholarly circles, when people talk about food addiction or ultra processed food addiction, as it's now being called, we're talking about a substance addiction, and the substance is typically certain types of foods, ultra processed, hyper palatable foods, but it's highly individualized to the individual, to the person. Risk factors, personal or family history of substance use disorder, severe phenotypes of eating disorders, so severe and extreme severity specifiers in patients with eating disorders, typically eating disorders in the binge eating type. So binge eating disorder, bulimia nervosa, and in some cases as well of anorexia binge purge. Trauma burden. We know that historical and childhood trauma is associated. Higher rates of trauma are found in patients who have food addiction. There are higher rates of food addiction for Hispanic folks. And many of the patients have failed multiple trials, 3, 4, 5 of standard and good and full eating disorder care. So the chronicity, that 25% of patients who have chronic illness. And food addiction is not code. It's not a secret cover up or a code for weight loss or for abstinence. So these are the DSM-5 criteria for substance use disorder. And they are the same criteria that are used for food addiction. So in the next slide, I'll show you a comparison of eating disorder DSM criteria with food addiction criteria. So as we're reading through these, think about the eating disorder treatment criteria. And are they similar or different to what you're hearing now? So use in larger amounts or for longer periods of time than intended, unsuccessful attempts to cut down or quit, excessive time spent using the substance, intense desire or urge for the substance, cravings, failure to fulfill major obligations, continued use despite consequences socially or interpersonally, activities and hobbies reduced, recurrent use in hazardous situations, recurrent use despite physical or psychological problems caused or worsened by the use, tolerance, withdrawal, and clinically significant distress. And this table shows you similarities and differences between anorexia restrictive type, anorexia binge purge type, bulimia, binge eating disorder, and food addiction. So when you see 2 X's, that criterion is a necessary diagnostic feature. So in order to have the diagnosis, for example, for bulimia nervosa, you need to have binge eating episodes. You'll notice that for food addiction, you don't need to have that. I want people to look particularly at the 2 areas about midway down where you don't see the 3 areas where you don't see an X in the food addiction column. And let's look at those. Intense fear of gaining weight, self-evaluation, unduly influenced by body shape and weight. So fear of weight gain, body image distortions, and distress. This is not part of the diagnostic criteria for food addiction. It is for all of the eating disorders, except for binge eating disorder, and it's very commonly found in binge eating disorder as well. Restriction in food intake, not a part of food addiction. restriction of energy intake, recurrent behaviors that interfere with weight gain, or inappropriate compensatory behaviors. Again, not a part of food addiction. So there are people who think, well, food addiction is just like a different way to like call something an eating disorder, but it's actually a different diagnostic entity than eating disorders. It's highly comorbid with eating disorders. And when it is comorbid, for the patients that do have both, if we only address one, we are doing them a disservice. This slide shows food addiction research. If we are interested in research and into the literature, this slide shows pretty nicely after around 2006, 2007, an explosion of research for food addiction. And when you look at the number of published pieces on food addiction in 2023, this is a PubMed search, 183 articles were published last year just on food addiction. And total hits for food addiction in the title abstract, for as long as there is on PubMed, there are 1,035 articles. So there's a huge amount of peer-reviewed scientific literature on food addiction, and we largely discount it, we largely ignore it in eating disorder field. Its prevalence in eating disorders has been studied. The prevalence of food addiction as determined by the Yale Food Addiction Scale varies greatly across samples. In non-clinical samples, it's estimated to be around 12% of children and 14% of adults. In patients with eating disorders, the ranges are anywhere from 70 to 90%, especially bulimia and binge eating disorder. In eating disorder samples, we know that food addiction is associated with more severe eating pathology and psychopathology, higher reward dependence, higher harm avoidance. It's associated with clinical characteristics that are common with other addictive disorders like depression, anxiety, multiple addictions, post-traumatic stress disorders, and ADHD. And people with food addiction show more insecure attachment styles, higher impulsivity, consistent with other addictive disorders. And we know there are health disparities in food addiction, just like there are health disparities in eating disorders. A nationally representative sample of the US revealed that the prevalence of ultra-processed food addiction was substantially higher among Hispanic and Black individuals compared to non-Hispanic white individuals. So 32%, 16% versus 11%. Food insecurity has also been associated with a 21 to 56% greater risk of meeting criteria for ultra-processed food addiction. And these disparities, researchers think, are driven by two factors: food industry and the changes that have happened in the food industry. There's data that shows and documents that reveal that ultra-processed foods are disproportionately marketed to persons of color using similar techniques that big tobacco used. And the accessibility and affordability of ultra-processed foods, the high reward properties of ultra-processed foods makes them a highly enticing choice for individuals with limited time, limited financial resources, and who endure chronic stress. And when we talk about intuition, I think we need to pause when we think about what's intuitive and what's not, because there's data that shows that big tobacco and the big tobacco playbook has been sort of carried over to big food. And we know that from people that look at global health, diet-related diseases, nutrition-sensitive diseases have increased along a similar timeline as industry-driven changes in the global food system. One example, when Kraft Foods and General Foods were acquired by Philip Morris, that we saw an increase in development and distribution of ultra-processed foods. And there are documents from the industry that show that tobacco industry leaders applied the same techniques to enhance the addictive properties of tobacco products as they're using in the development of ultra-processed foods. And these are, this isn't with any human being's interest. This is to maximize profits, right? And the big food and big pharma and big tech and big diet and weight loss industry, those are not, huge lobbies that are influencing lawmakers and influencing policy that care one bit about any of the individuals at the individual level on the screen. And when we talk about treatment, I just want to spend a little bit of time talking about treatment, and then we can open it up for discussion. Trauma-informed, trauma-informed, trauma-informed. It needs to be trauma-informed across the board, really. Diagnostic accuracy is critical, appropriate level of care, ensuring safety medically and psychiatrically, and nutrition therapy, individualized. Can we tailor our nutritional plans to individuals' bodies, individuals' brains, individuals' preferences? And can we let individuals define health and define their values, right? We can continue to help people combat weight stigma and fat phobia and diet culture, and to really internalize their own definition of recovery and health, what they value, and we can help them get there. But it's hard to do that if I'm taking a paternalistic approach to treatment, and coming into any therapeutic relationship with the idea that I know better than you, because I'm a trained psychiatrist and because I have 20 years of experience treating people with eating disorders. On day one of meeting a patient, the amount of experience I have treating that patient is 0 days, right? And I take that into account every time I meet a patient and every time I work with a patient. Skills building is part of treatment, family therapy, education and support, body-centered therapies, trauma-specific treatments, and then facilitating connection. I'm gonna, I do want to say one word about mitigating risks. We need to make sure that diagnosis is accurate. It would be very, very harmful if somebody who had an eating disorder was misdiagnosed as having food addiction and was supported in a nutritional plan or a nutritional approach that could worsen the underlying eating disorder. There's also risk to somebody who has food addiction, whether food addiction alone, and misdiagnosing that as an eating disorder, or an eating disorder comorbid with food addiction and not acknowledging a food addiction. Pathologizing a person's subjective or intuitive experience by inappropriately categorizing a trigger food, a legitimate brain reward sensitivity food for that person, as being merely a fear food and attributing that to a restrictive, over-controlled eating disorder. And part of how to mitigate these risks is to use standardized tools and good clinical judgment. There are a lot of standardized tools available, but also, listen to your patients and monitor them closely. Close work. Try things, experiment, check the results, and keep going. And I think we can end it there. I'll say, one last thing. I just want to thank ANAD again. I want to thank my organization here for supporting me, but ANAD as well for being brave enough to hold this conversation. and for all the work you've done over the years and continue to do to advocate for people with eating disorders, and to include to cast a bigger net.
Absolutely, absolutely. Thank you so much, Dr. Kim. It's one of these things that it's so important that we have these conversations, because that's how we make change. That's how we make progress, and we can bring healing. So we've got some great questions in the Q&A already. So I'll go ahead and read a couple of these off, but also feel free to bring yourself off mute or to comment in the chat if you have anything that you want to add to the conversation. But the first couple of questions that we have kind of center around food addiction versus binge eating disorder. So if you could maybe dive a little bit more into that. One of the questions is, do you see physical or psychological restriction as a cause or contributing factor to food addiction or not, in terms of thinking food addiction versus binge eating disorder?
So I'll start off with saying, I don't think one versus the other, because they're not mutually exclusive. So sometimes it's binge eating disorder, sometimes it's food addiction, sometimes it's binge eating disorder plus food addiction, right? And part of how, part of how we go about like determining that is, one, using standardized tools, using the diagnostic tools that we have, taking a detailed history, getting collateral from family members and other treatment providers. But there are restrictive dimensions that can be part of all of the eating disorders, and something that may look like dietary restraint, may be part of food addiction as well. And it can be bi-directional.
Yeah, and following up on that, another question that we got was, any thoughts on food insecurities relationship when it comes to food addiction?
Yeah, well, we know there are higher rates of food addiction among folks who have food insecurity. And I think, part of that is the question of access and traumas that go along with, or that are more likely to occur for folks who are food insecure. We know that trauma increases the risk of eating disorders, increases the risk of depression, PTSD, trauma is connected to all of these things, right? And I think when people are food insecure, from that in and of itself changes their relationship with food, right? Food is this thing that we need. We need it to survive. And if you don't have access to it, that's kind of a life and survival threatening situation that you're dealing with.
And that kind of ties into another question that I saw here in the Q&A, but it was, somebody was asking, they were curious how you can compare substance use disorder to food addiction when substance is not required for staying alive, but food is required for staying alive.
Yeah, well, there are lots of different answers to that. For people ask that question a lot, right? But we can compare it to alcohol use disorder, right? Alcohol is a substance. You don't need alcohol to stay alive. I do need to drink to stay alive, and I need to drink every day, and I need to drink multiple times a day, right? I would die a lot sooner if I stopped drinking today. So I need drinking to survive. I just don't drink drinks that have alcohol in them, right? But food addiction is more similar, I would say, to caffeine addiction, to nicotine addiction, right? Think about somebody vaping. Caffeine is, when we think about, if we're making comparisons to substance use disorders, I think substance use disorder addict conjures up this like really impaired, out of control person, right? The gutter drunk, or somebody under a bridge with, paraphernalia spread out around them. But addiction comes, there are many like fully functional, going to work, raising their families, people who have addiction of various sorts, caffeine and nicotine being among those. But we do need to eat, we do need to eat every day, multiple times a day. Like I eat 6 times a day at least. And we don't need to eat, certain types of highly processed foods. Like I'll use an example, like don't need to have you don't need cupcakes to stay alive, right?
Mm-hmm.
Or X, Y, or Z other, like there are certain food substances that for some people, they may not end up having in their meal plan, right? And they still stay alive. They still have a calorically robust meal plan, with a lot of flexibility in it, with intuitive eating in it, that just doesn't happen to include all foods under the sun.
Yeah.
You know,
Yeah.
most foods, not all.
Right. Right. All right. And everyone, continue to add your questions if you've got them. Another question that popped up here in the chat is somebody was just asking to better understand the connection between all foods fit and the shame that your patient was referring to in that quote that you shared.
Yes. So look, can I ask, I don't think I could see everybody on the screen, but is there anybody on the screen who has lived experience with food addiction? I see a hand raised. If you are brave enough, would you be willing to unmute and say if you related to what that person, the quotation that I shared? And if not, that's okay too, I understand. Still a little anxiety provoking. I'll share. So, and I have okay. So for example, I think what this patient was talking about was, this is a person who had been in, eating disorder treatment programs after eating disorder treatment program after eating disorder treatment program, where she repeatedly said, there's this certain type of food, when I eat it, I can't stop eating it, and when I eat it, I feel like I want to eat more and more and more and more and more, most of the time when I eat it. Not every single time, but like 90% of the time. And I may be able to eat it just fine, like when I'm in the treatment program, and then I go home and like I can't stop binging. And I go back to the treatment program and they tell me all foods fit. We're just going to help you eat it in moderation. And she would say, I really don't like this food, feels like, a drug to me. I can't stop eating it once I start. And that experience was discounted. So she felt shame that she didn't fit in with well, all foods fit for all these other people who are doing well in their recovery. What's wrong with me? I suck. Like I failed treatment again. So I think that's what this person was, was referring to, and she was told, no, you can't, not have this food because that would just mean that you're sick with your eating disorder. She was like, I don't think that's part of my disease. I think it would actually be part of my recovery to not have this thing. Does that make sense to whoever asked the question? And you can unmute and engage too.
All right. Well, there's another question here in the Q&A that actually it came to mind for me too. But someone was saying that they've always thought of eating disorders as a form of addiction, an addiction to preoccupation, rituals, escape, and false hope of dieting. So why do you think that an addiction frame is helpful in treatment?
Yeah, well, I think it's, again, I think this is helpful depending on the patient. You know, if a patient comes to me and says this feels like an addiction to starving or an addiction to dieting or an addiction, you know, my ritual with my food rules, um, I don't know why I'd say like, no, it's not. We don't use that word in eating disorder treatment, you know, like, uh, and I don't think any of us as professionals do that, but I think in our heads, like all sorts of flags go off if somebody comes to us with that. But there's a difference. Part of why I said, you know, when I talk about food addiction and the language of ultra processed food addiction, that entity is really talking about food addiction as a substance use disorder, like food substances, certain substances in food, not all food, obviously. But there are also behavioral addictions, right? Like problematic gambling is probably like compulsive gambling is the best example, right? And that doesn't involve a substance, but it is a very serious addiction with a high rate of suicide. And I believe there are people with eating disorders who do better and who prefer and who want to be treated from an addiction frame. I think part of the resistance to that in the eating disorder world, part of the stigma associated with it is most people associate addiction treatment with restriction, right? Like, oh, you're going to restrict what they can do. But really, addiction treatment is about expanding what people can do and limitless expansion, really. And there are lots of different ways to treat addiction. And harm reduction is one that we use in both fields. You know, no, like every eating disorder, every form of treatment really essentially is a form of harm reduction, right? Because when a patient comes in day one of treatment, they're not going to be having 5 challenge foods a week, right? Like we're just going to start from, where they are and we're going to build up on that, you know, gradually reducing harm and gradually improving and increasing freedom. And you know, I think all addiction treatment and all eating disorder treatment at its essence is that, because nobody, you know, no doctors want to add harm. No clinicians want to add harm to anyone ever. So. Oh, you're muted, Jason.
Unmuted. The screen was yelling at me too. So we have about 5 minutes here. If anybody would like to come off mute and perhaps share a story or excuse me, share a question. Molly, I see your question. Yes, we are going to send a recording out after this. So we will have this webinar recorded and I will get that emailed out to everybody. But if anybody has any additional questions for Dr. Kim, definitely feel free to ask those now. All right, it looks like LP
There's
got your
one.
hand
Yeah.
raised.
Sorry, just coming off mute here. I put it in the questions as well. I've really struggled as a primary caregiver for my wife, repeatedly labeled as treatment resistant. And I'm really struggling looking ahead and trying to find some hope in future treatment for her, because being closest to her, I see it all as part of the illness and not by choice, right? And
Yeah.
and if we can't get past that with the professional field that needs to support her, I don't know what to do. So it's just such a stigma for me. What's your thoughts on that?
My heart goes out to you and her. I know very well it's not a choice, you know. And I think far too often you know, whenever I hear clinicians that I supervise say like, well, the patient doesn't want it yet, or the patient's just being resistant, like, whoa. Like, you know, and I think that's part of what you're touching on. You know, I don't believe anybody, if they truly had freedom of choice, would choose an eating disorder, or an addiction for that matter. And I do think it's our job as clinicians to, you know, to try everything we possibly can under the sun to try to help a person when standard treatments don't work, and to do so in a way that doesn't add shame or stigma to a person who is suffering. You know, our treatments failed your wife. We failed your wife. You know, she's not failing. You're not failing. So you know, my heart goes out to you. I would say keep trying, and keep trying different things and different techniques and different providers, because I do believe there's an answer for you and for her. And at the very least, I think we need to be, you know, treating patients, treating each other with kindness and respect, always, especially people who are suffering. Thank you for unmuting and asking that.
All right, we're almost to the top of the hour, so we maybe have time for one more question if somebody's got it. Otherwise, Dr. Kim, how is the best way to get in touch with you and to check out SunCloud Health?
Yeah, so our website is www.suncloudhealth.com. And I think I left on my last slide. On my last slide, there'll be an email address under my name. It's info@suncloudhealth.com. If you want to ask any other questions, just feel free to email me at that email address.
Wonderful.
I'd be happy to hear from you.
Well, again, I really appreciate you joining us for this conversation today. I'm glad that we were able to host this and give the platform to have these types of conversations. I will send out a recording of this event to everyone who registered. I'll also make sure to include links to SunCloud, links to ANID's support services as well. And everyone, I want to thank you so much for joining us today, and I hope you have a great rest of your week. So take care, everyone.
Bye, everyone.